Okay, good evening, everyone. I'd like to welcome everyone to tonight's MSIG webinar, where we're continuing the MSIG webinar series on textbook injuries. This is a series where each speaker will share their expertise on a specific sport and identify the most common injury or injuries from the sport. My name is Jennifer Addleman, and I am one of the AMSSM MSIG officers this year, and I'm currently serving as vice president. I am a fourth-year medical student at Touro University, California, and a certified strength and conditioning specialist, currently applying into physical medicine and rehabilitation residency. Tonight, we have a really outstanding speaker panel for the MSIG webinar Textbook Injuries, where Dr. AJ Monseau will discuss wrestling, Dr. Michael Kelly will discuss boxing, Dr. Bryant Walrod will discuss mixed martial arts, and Dr. Mark E. Lavallee will discuss weightlifting. It really is an honor to have these 4 AMSSM members serve on the webinar speaker panel. After their 4 presentations, I will serve as a moderator for a Q&A with our speakers. Please enter your questions in the chat throughout the entire webinar, and I will read each question during our Q&A segment at the end. Now it is my pleasure to introduce our first speaker tonight, Dr. AJ Monseau. Dr. Monseau is a professor of emergency medicine and sports medicine fellowship director at West Virginia University and serves as the head team physician and medical director for WVU Athletics. His interests in sports medicine include concussions, athlete and coach communication, wrestling injuries, and emergency management and preparedness. Dr. Monseau, you have the floor.
Thank you very much, Jennifer. It's great to be here. I'm happy to be talking about wrestling, which is something that is near and dear to my heart. So let me get this started here. There we go. Sorry about that. So, again, it's great to be here with you all. So I'm going to talk about wrestling. Of course, we have about 10 minutes or so. So I know each of us could probably talk about our individual sports for easily 50 or 60. So let's try to get right to it. No disclosures. I do work closely with USA Wrestling, just a volunteer position. We're going to talk about how I get involved with wrestling, some very basics of wrestling for the team physician, and then kind of what is the most common injury. So I got involved with wrestling. I grew up with wrestling. So this is my dad. My dad is now 84 years old. He has coached or started coaching when he was 21 years old, spent about 10 years in high schools, spent a little over 30 years at the college level before returning to some high schools to be a principal and a wrestling coach. When he was 75 years old, I went to give him a hug at Christmas time, and he pulled back and said, "Oh, don't hug me. I'm sore. I was wrestling with the 112-pounder yesterday." And I said, "Dad, what are you doing? You're 75 years old." And in classic wrestling coach style, he said, "He's only 112." So that's what I grew up around. That's who I wrestled for in college. And so, I've kind of come up all through that. When I got into medical school and I knew I wanted to be more involved with sports medicine and eventually in residency, I volunteered at some national wrestling tournaments to help with the medical staff. I made the 3-hour drive from Morgantown up to Akron to help with one of the national tournaments that was held there. I put my name in with the medical pool, as I would encourage all of you to do eventually. And it was for a few years, I didn't hear a word, which is as these things often happen. And then all of a sudden there was a need for someone on a trip because someone pulled out of a January trip to Siberia, which is just as beautiful as you might expect. And so I got to jump on that trip and spend a couple weeks in Siberia in January and February. And since then, I then worked on several international trips and then a couple of world championships before eventually doing the Rio Olympics. So that was my route into getting involved with wrestling. I would encourage everyone, if you have a sport that you love, is just put your name out there and start showing up for some things, and eventually some opportunities will likely open up. It may take a while. You just got to be a little patient, but that's how I got involved with wrestling. So let's hit some basics. So if you're on here, you may already know a lot of this, but American folk style wrestling for both the high school or middle school or kind of lower levels as well as collegiate. For the international and Olympic styles, those are men's and women's freestyle and Greco-Roman. Women's NCAA wrestling, which is an emerging sport, is contested in freestyle. So that is the only kind of outlier there, is that it is an NCAA sport, but it is freestyle. Some differences kind of come down to the main impetus of each sport. So for folk style, the focus is on control and holding an opponent on their back, whereas in freestyle and Greco-Roman, there's more of an emphasis on the takedowns and back exposure. Greco-Roman, especially though, is quite different because you're not allowed to attack the other person's legs or use your legs in a way to trip them in any way. So it makes it appear very different. So that's the timing is a little bit different. So in folk style, there's 3 periods. In high school or middle school, or well, high school it's 2-2-2, and then in college it's 3 minutes for the first period, and then 2 for each of the last 2. In freestyle and Greco-Roman, it's only 3 minutes for 2 periods, and then the positions are a little different. So in high school and college wrestling, there's a neutral position, top and bottom as well. Whereas in the other styles in freestyle and Greco, they refer to the top and bottom position as parterre, and they're really only allowed to work on that position for about 15 seconds before they put you back up to your feet. So it appears a little different. The emphasis is a little different. It does make for slightly different injury patterns. So we'll touch on that just a little bit later. Basic, so skin check. I know this is really tiny print, so that's why I put the QR code on there. If you really want to shoot that, you can. This is the NCAA skin check form. This is really helpful, not only for educating yourself, but also for your boards someday. There are frequently questions on these skin things on there. They're very easily testable. Interesting things on here, there are some things you're allowed to wrestle with. There are some things you're clearly not allowed to wrestle with. There are some things you can wrestle with if you can adequately cover them. I'm not going to dive into all that. That's not the purpose of this tonight, but just to know it's out there. Skin checks usually happen with the athletic trainers, with physician support, or sometimes at larger tournaments, it's completely physicians who handle the skin checks. So the other thing in wrestling, it's a little odd than other sports, is there's time limits for your injury timeouts, and that's important to know as a team physician. So in folk style, if there's bleeding happening in college, it's unlimited time to control the bleeding up until a point. Clearly, if it's going on forever or significant bleeding, the referee will likely at some point step in and stop it. In high school, you only have 5 minutes. So that's a pretty hard cutoff. And so you really have to work hard to get the bleeding stopped as quickly as you can. For injury timeouts in college, you get 1.5 minutes for injury timeout. You only get 1 timeout. At the end of that timeout, the opponent is going to get their choice of what position they restart in. And if you take a second injury timeout, you're disqualified. In high school, you get 2 timeouts. The opponent gets their choice after the second. Again, it's 1.5 minutes, and it's after the third timeout that you would be disqualified. For concussions, it's a little different. Thankfully, in the last several years, this was changed. And so now in college, you have an unlimited and unimpeded time to manage a concussion. That may involve taking the person out of the arena into the locker room, into some medical area, an exam room to do your exam and allow for that. And they allow extra time for that. In high school, you only have 5 minutes for that concussion evaluation. So again, you have to be cognizant of these times. In freestyle and Greco, we always say that the time for these is unlimited in international styles, but I have never been yelled at more than when a timeout is happening with international wrestling, and the referees are usually right on top of you, yelling, whether in English or some other language, for you to hurry up. So there's not really a limit, but there frequently feels like there is. So when I was asked about most common injuries, I actually messaged Michael and Bryant because I didn't want us to overlap too much, because I figured our 3 activities or sports here overlap to some extent. So I wanted to avoid that, because what I stumbled upon in my research for this was that I've got a bit of a dichotomy or dilemma here, which is that in the high school, NCAA involves season-long data. And so the work for that shows that knee injuries are the main or the most frequent injury, the most common injury. Whereas for the Rio and Tokyo Olympic tournament data that was published in 2024, earlier this year, they showed that skin lacerations or skin injuries were the most common injury. So I took that, I talked to both of them. I don't think they're going to cover either one of these, so I'm just going to hit both of them. So I just make it quick. I'm still cognizant of my time though. So knee injuries, right? So we all see this. If you cover wrestling at all, you see a lot of wrestlers end up in this position, whether by necessity, by choice, or by accident. This is a common injury position. They frequently will injure MCL or LCL. There's meniscus injuries happen frequently, and then ACL. If you recall, a few years ago, Spencer Lee at Iowa famously won his NCAA title with no ACLs. He had already entered the season without one and then tore the other one 2 weeks before the national tournament in the Big Ten tournament and competed on with no ACLs. Something that most other sports that'd be very, very difficult to do, but in a contact kind of grappling sport like this, it is definitely possible. When you're doing your exam on these people, you need to make sure that you account for baseline laxity. Many of them are extremely loose jointed. You want to make sure you're checking that with both sides. You want to take account of any recent injury or prior injury history that they've had. Sometimes it may be that they had a prior ACL tear, that knee has always been a little looser, and so they can do things with it like you might see our wrestler do here at the top. There are some taping techniques, especially for those MCL and LCL injuries, that can be very helpful. For the ACL injuries, whether it be post-repair or an ACL deficient knee, physical therapy will really focus on hamstring strengthening to help compensate for that. We've had one of these a few years ago. We did that physical therapy. We also put them in a high-end custom ACL brace. That was very helpful. They were able to participate quite highly and were an All-American that year. So it's definitely doable. Lacerations being the other one. See lots and lots of these. I see some very creative taping jobs around the forehead, like this is the common one over the brow. I've seen them go kind of a chin strap mechanism to cover a laceration on the top of the head. Occasionally you'll see ones that go straight across the nose. This would be, I feel like that'd be really hard to wrestle with, but I've seen people do it. I focus usually on simple sutures. I will mix in some vertical mattress sutures if there's a fair amount of tension. The other time I use vertical mattress sutures is if I have a wrestler who really, really, really does not want to wear a head wrap, then I may throw a couple vertical mattress sutures in there just to make sure I give it some extra strength to allow them to possibly participate without the head wrap. Then we usually go with some coverall over that and some Vaseline on top of that to help with, kind of anything that would cause further abrasion. I stay away from horizontal mattress sutures. Those will cause some ischemia there at the wound edges. I do not use those, just the vertical mattress is where I do. I don't use absorbable sutures on the skin. I know there are some people out there that do that. I don't know that it has a place in combat sports, especially just because it inherently is a slightly weaker suture. So I don't use those there. You're going to want to reinforce that with steri strips, both in competition as well as after suture removal. I'm not a fan of glue. I know a lot of people use it. I just find that it breaks open frequently. For some lacerations that really show no tension, I might use it, but it's pretty rare for me. If somebody does use glue, you need to get it off. Remember, use acetone. You can use that to get that off of there. My last thing, though, is that through all of this, I was very confused because somehow it seems like the most common injury for both not only my sport, but I'm going to guess MMA and boxing as well, is an auricular hematoma. So an auricular hematoma is probably the most common injury. I think we have somebody who's not muted. So these are not accounted for in those studies, funny enough. So just a couple points about this. Many at this point try to do these at home. I, of course, discourage that. There's a high risk of infection with that. I really ask our wrestlers not to do that. You're going to need a big needle to get that out of there because there's likely going to be some clot involved as well. You got to close the potential space somehow and give it time to heal if it's actually going to heal. Many of our wrestlers look at this as a red badge of courage. They do not really care whatsoever. Their mom might care, but they don't really care usually. So you got to give it some time to heal. Classically, you would use some gauze rolls. You can suture those in place. You can use a button and suture that in place. Even a head wrap, if they'll leave it on for long enough, will at least provide some occlusion there. I personally like dental impression material. I keep this in my bag to use to provide a nice splint onto that ear and form it without providing too much pressure, because I do caution some of our athletes are beginning to try to use these market magnetic devices that are out there, which will help provide some compression. Unfortunately, there are case reports of those providing too much compression and a pressure necrosis and a perichondritis. This is not one of those devices. This is just a Google image of two magnets. I didn't want to single out any product in particular on here, but you can see what those are if you look online quickly. That is my talk. Thank you very much, and look forward to hearing the others.
Thank you, Dr. Monseau, for your presentation. Now it's my pleasure to introduce our second speaker, Dr. Michael Kelly. Dr. Kelly has been a board-certified sports medicine physician for over 20 years. He has authored numerous journal articles, books, and textbook chapters on combat sports injuries. He is currently the chief ringside physician for the New Jersey State Athletic Control Board. And now, Dr. Kelly, please proceed with your presentation.
Thank you for the generous introduction. AJ, I really liked your talk, especially concerning cauliflower ears. I've had similar experiences. So my background getting into sports medicine and becoming a ringside physician seemed like an evolution. I have a background in martial arts since I was 6 years old and wrestling and as a kid, high school and college. During medical school, I was very, I'm sorry, somebody said? During medical school, I spent quite a bit of time researching on combat sports injuries, and it actually led to the publication of my first book. Ironically, when I was doing my residency, the chairman of the intensive care unit read my book and came up and approached me and suggested that I apply to UPenn for the sports program. I wasn't going to do it initially, and he was very persistent and recruited pressure from the chairman of medicine and the program director. At that point, I felt like I had no choice, so I did apply and subsequently got in. Then during my fellowship, I was late for rounds and I was running to an elevator, and I bumped into an elderly gentleman in the elevator in the hospital. And we just started joking around, talking. He was a real nice man. And he saw the sports medicine tag on my lab coat, and he asked, he said, what do you do with sports medicine? And we just started talking. And then I told him I had a background in martial arts and I had researched it in medical school, and that's how I got into the fellowship. Then when we got to the bottom level, he introduced himself, and he was the chairman of the New Jersey Medical Advisory Board for combat sports. And I was shocked. It was just pure serendipitously that I had bumped into him and started talking. Within a few months, I was appointed as a ringside physician. And actually, my first bout that I covered was a championship, a title defense at Boardwalk Hall with Arturo Gotti, and it was electric. I was hooked from that second on. I think one of our other physicians is going to talk more about the duties of a ringside physician, but basically, just very briefly, ringside physicians will review pre-fight medical requirements, and these vary by state, but can include serial brain imaging, serology for different infectious diseases, as well as ordered tests from prior fights that other commissions may have determined that the fighter needed before they'd be allowed to compete at the professional level again. The hard part of ringside medicine is making those decisions. Do you allow the fight to continue? Do you stop it? And this is actually hard for any physician in any combat sport. I'm going to talk about how we determine whether or not an injury is severe and what we look for during the bout and when we go into the ring to try and make that determination quickly. And we're all sports medicine physicians, and many of us experience sideline medicine where a lot of information about concussions, how to evaluate them. I thought this cartoon was great because it sometimes when I'm listening to the trainers ask the athletes about their concussive symptoms, it does seem like it gets pretty complex, especially from the view of a ringside physician, where we have about 30 seconds, if that, to make our determination. The way we do that is observation throughout the bout. From the minute they walk into the cage or into the ring, we're observing everything about that fighter. In New Jersey, we developed this, what we call rapid fighter assessment, and it's pretty much just an organized stepwise approach of what every ringside doctor does, what every commission does. We just put it into a simple format for the new ringside physicians, and we concentrate on the eye movements. I'm going to talk more about them. Big indicator is basic response to questions. Is it delayed? Are they accurate? And everybody knows that when you're assessing brain function. But one thing that's often underappreciated is the fighter's willingness to continue. If you ask a fighter if they want to stop, they get mad, very angry, and in your face say, no, I'm fine, I'm fine, I'm fine. When they don't do that, when they're not angry and not in your face, answering quickly, that's when, as a ringside physician, we start getting worried. The other thing we talk about is mostly looking at the performance. Are they ataxic? Is the coordination changed? How are they moving in the ring? And that's what I'm going to concentrate on, number 3. Starting off with posture. You look at a fighter before a bout or when they're in the corner and they're good, they're ready to go. They look very calm and composed, and notice the gloves are almost 99% in front of them when they're not injured. I'm going to show you examples of when their gloves are falling to the side. When we look at the posture of an injured fighter, and I think this is any combat sport, when that initial real bad pain or real bad hit, almost universally, human beings will go very quickly into a fetal position. They may come out of it, but they'll crouch down and go into a fetal position. Fighters will reflexively start trying to grab something, go into a clinch to buy some time. Sometimes they're so out of it, instead of clinching their opponent, they're clinching the ropes. The other thing I personally look very closely at more than anything, and I think most experienced ringside physicians watch, is the footwork. If you watch a high-level professional championship fighter, invariably the rear foot, the heel is up, and they're moving gracefully as they're moving around the ring, mostly on the balls of their feet. It's different in MMA, and I know one of my colleagues is going to talk more about MMA, but MMA, Muay Thai, and other combat sports where there's kicking or grappling, that may change. But in boxing, which I was asked to mostly focus on, that heel is usually up and they're on the balls of their feet. When they get injured, their feet spread out very wide and they go on their heels. The heels get planted into the ground. And then if you look at the gloves, when I said somebody's really injured, the gloves are no longer in front of them. Both these pictures, you see the hands down, the gloves going out to the side. The thing we watch very closely is coordination and the ability. Boxers spend hours training on their hand coordination and their accuracy. When they suddenly start missing, there's usually something wrong. If you go on YouTube, there's a video of within the past 2 years of a fighter who took a couple of bad blows in the ring, and he starts punching in the air 90 degrees to his opponent. The opponent is looking at him in shock, like, what is he doing? But we call that phantom fighting, and oftentimes you'll see that when somebody's got a concussive or more serious brain injury developing. In 2015, the Department of Defense released a study showing that they can predict concussive or traumatic brain injury with 90% accuracy just by looking at the eyes and with trained ophthalmologists. And we look for this in fighting, and there are a number of different things that we look at when we go in the cage and we're looking at the fighter. We're not really doing extraocular movements, or we're not shining the light in the eye. That nobody's got a Marcus Gunn pupil or a blown pupil when they're sitting there talking to you. But the big thing we look for is changes in the saccades, obvious horizontal gaze nystagmus, and the easiest one is that change in near point convergence. If you look at the picture of Roberto Duran, you can see his pupils are actually converging as he's looking at his trainer talking to him. When they get injured, particularly a bad knockout, or if they have what's called a pummeling knockout, which I'm going to talk about in a minute, they lose that ability to converge their eyes. So they stare off into the distance with their pupils being parallel. This is referred to in the military as that 1,000-yard stare, when somebody's been around a lot of concussive brain trauma from blasts and other injuries. But if you look at the example on the right, she's staring off, and you can see how her pupils are parallel, and she has that unfocused look. I'm going to talk about knockouts. The older boxing literature, the medical literature in boxing, talks about different classifications of knockouts. And I think this is used more as an educational tool to teach new ring doctors what to look for. But if you look at this, this is what we call a brainstem knockout. The head spins so far with that rotational force on the chin that there's a kinking of the brainstem and a very quick knockout. This particular bout, this fighter woke up in about 3 seconds, walked around the ring, watched the rest of the fights with 0 sequelae. That's reassuring. These knockouts, although they may look really bad, they usually have minimal sequelae. They do really well. Similar, some people will correlate what's called a flash knockout, which is a very brief loss of consciousness, with a direct linear blow. The belief is that it's a similar kinking mechanism in the brainstem, but this is usually on the button of the chin or directly in the face. And the fighters tell me when they get hit that hard, their legs just shut off and they go down. They may have a loss of consciousness, they may not. They may regain their consciousness by the time they hit the canvas, but usually the fight is stopped very quickly. This is the one, if you go back all the way into the boxing medical literature of the 40s and 50s and 60s, the pummeling knockouts, there's another vague German term for this, von Hemmenbergs or something similar to that, where the fighter is out on their feet and they're just taking sustained punishment. And this is the one that leads to the highest risk of chronic traumatic brain injury, or what's also known in the past as dementia pugilistica. These fighters are standing, but they're not really conscious. Fighters have told me they describe a fugue state where they know what's going on, but they can't move and they can't really correlate like a sense of time. Problem with this type of knockout is the sustained punishment causing further injury to an injured brain. And that can lead to, the last thing I'm going to talk about is the severe brain injuries and death in the ring. It does occur. It's occurred in almost all combat sports. We see it the most in boxing. We do see much lower incidence in MMA, but there are some cases. Because of this, if a fighter is injured in the ring, we have a very low threshold to order an urgent CAT scan or MRI of the brain, because we know that there's a much higher risk of a brain bleed as opposed to a simple concussive injury because they lost consciousness. The most common cause of death in the ring is a subdural hematoma. So in summary, my career in sports medicine and resulted in 20 years of being a ringside physician, currently serving as the chief for New Jersey, basically started with a very good training where my instructors, my attendings had an interest in me and knowing what I was interested in, pushed me in a certain direction. And that incredible conversation on the elevator, you always hear these stories about elevator stories where people, their career takes off from somebody who they spoke to in an elevator. And that really happened to me. Take home points, remember ringside evaluation is different than sideline evaluation. And it's important to remember that because in the ring, it could be not just a simple concussion or even a complex concussion, it could be an intracranial bleed leading to death. And you gotta get those fighters to a hospital, trauma center as soon as possible. Of the different knockouts you may see, remember the pummeling knockout is the one that's really the most dangerous. Good ringside physician is observing when the fighter walks in the ring, during the bout, when they talk to him, after the bout, and the things you need to concentrate on, the posture, coordination, footwork. Remember that heel. If that heel is elevated and they're moving gracefully, that's the mark of an uninjured fighter. When the heel goes flat and they're suddenly become ataxic, now we're most likely dealing with an injured fighter. And if you can't remember the ocular movements and indicators, there are a number of them. But if you remember nothing else, remember that loss of near point convergence. Finally, every fighter that gets assessed, you should ask, do you want to continue? If there's a pause, that's unusual for a fighter, and you need to really look at them closer. Thank you.
Thank you, Dr. Kelly, for your presentation. Now it's my pleasure to introduce our third speaker, Dr. Bryant Walrod. Dr. Walrod is an associate clinical professor in the Department of Family and Community Medicine at The Ohio State University, and he is the Associate Fellowship Director for the Primary Care Sports Medicine Fellowship at Ohio State. He also serves as head team physician for Ohio State Buckeye football. Dr. Walrod has over 20 years of experience in mixed martial arts coverage of over 1,000 bouts. He has multiple publications and presentations on mixed martial arts ringside coverage. He is currently studying hydration and its effects on sparring. Dr. Walrod is a former collegiate boxer as well. And now, Dr. Walrod, please proceed with your presentation.
All right. Can everybody see my slides okay? Give me a thumbs up. Yep. All right. Great to be here. Great to see some of my colleagues and see some people I haven't met. Great first two talks. I'll take a little bit different angle as well, which I think is kind of neat. We all kind of have some different approaches. So I'm not going to go into great detail because of time limitations, but talk about some basic ringside considerations, post-bout evaluations and injury patterns, return to sport concerns. And I do want to talk on two things that are very kind of near and dear, and that is hydration, weight loss, and return to competition after concussions. So if time permits, I want to talk about that a bit. So these were kind of some of these questions we wanted to ask, then I'll get into some more detail. How did I get involved with sorry, so first, how did I get involved in sports? So I was a college boxer at Miami of Ohio. We were the NCBA. Just kind of stumbled upon it. I did football and track in high school, and just kind of stumbled upon boxing by one of my people in my dorm, and then really got into it and got pretty involved. Was the president of the club. I actually started a women's boxing club, and stayed involved and really liked it. Had multiple sanctioned bouts for the NCBA, and then got in through med school, got through residency, and then when I moved to Wisconsin, I became friends with Dave Strasser, who's a former UFC fighter, and he had a small gym in Kenosha, Wisconsin. And that was kind of where I got more exposed into MMA. This is probably around 2004 or 5, when kind of the early stages of the UFC, if you will. So I really got real involved in the Southeast Wisconsin kind of corridor for MMA. And then that kind of took me up to Madison, Wisconsin as well, where I covered lots of fights, Madtown Throwdowns and stuff like that. So lots of exposure kind of in some of the early stages of MMA. So just to kind of go over some of the questions, probably the biomechanics of the sport. I think it's just inherent in the name mixed martial arts. It's very variable. So I can't say there's really like a biomechanics that you would say is classically associated with it. You'll see that strikers would probably have more head trauma, whereas grapplers may have more lower extremity trauma or extremity trauma. Single most common injury, at least from what I see when I cover these events, would definitely be where I'm called to help, is laceration repair. Exam skills to diagnose the injury. You need to be able to obviously fix lacerations, being able to handle soft tissue injury, fracture, joint dislocations, and concussions. Why is this important? You know, despite we see UFC continuing to grow and grow and grow, many major organizations have called for the ban of mixed martial arts. So if we start to ban it, could this make the sport more unsafe? Could we potentially get to underground competition? That's where I think the biggest concern is. With the regulation of UFC and some state sanctioned bouts, it isn't as concerning as some of these smaller venues that might not have the a regulation and then oversight. You see the participation in MMA continues to very robust. Over 2 million people are participating, all the way down to age of 6 years. Competition, about 1 million people actively say that they compete in MMA. To compare and contrast that with tackle football, so about maybe a half to a third as many people participate in MMA versus tackle football. And just think about all the rule changes that have happened in tackle football in the last 15 years. Much more common than wrestling as well. So I always kind of approach any way that I'm going to cover an event. I think of myself kind of three primary roles, or three roles. The primary is kind of health promotion, risk factor reduction. This is where I think your role to educate the athletes about hydration and weight loss are key. Secondary role is what you can do during the event, basically ringside management of problems. And then tertiary, how are you going to follow up with these people? So hopefully you'll have a chance to get to see these people post-bout, not just at the bout, but when you see them maybe in the gym. We'll jump back to one nice advantage of when I worked in Wisconsin with this small gym that I was a part of, was I was kind of their guy. And I think that was a unique but really nice kind of features, that if people did have things that would come up, I was the ringside doc that would cover the events, as well as I'd be there and be able to help them with respect to return to, we'll say, sparring, return to competition considerations. So how can we help? Obviously, you need to study, you need to be prepared, you need to get certified, know the rules at the ringside, understand the potential concerns about weight loss and hydration, and really understand what happens with respect to concussion. You'll see there's some inherent limitations state by state. Sometimes we have some limitations with respect to return to play protocols. So sometimes people can fall through the cracks if they're competing in different states. If you want to learn more, I would recommend you look into the Association of Ringside Physicians. They have their recommendations with what it takes to become a ringside physician. Here's just some information about the state of Ohio. And to be brief, you know, all states are going to have their own pre-participation physical examination form. This is what we would see here. One thing that you'll see for MMA, I have it highlighted here in yellow. People that have had LASIK eye surgery are not allowed to compete. There's concern that the flap can dislodge. If they have concerns and they want to consult you before having surgery, the PRK surgery is acceptable. And then you'll see when you do the post-bout form, you can talk about how long they might be out. But again, this is kind of concerning because not all people fit into one size. When might you be asked to stop combat? If there's an intentional foul, like a head cut from a headbutt or an intentional foul, they may ask you to come in and to examine the wound. It's really important you just examine the wound. You're not going to try to treat this wound. You're just going to examine the wound and decide whether the combatant can continue or not. You know, so you'll be sitting there, some of you are residents, they say, hey, doc, can you cover this fight for us? Well, you got to think about what that entails. What kind of things you're going to have to think about when you go to, quote, cover a fight. Who's coming with you? You can have a team of medical providers. Back in the past, when I used to cover more, I had a lot of residents, other physicians, athletic trainers. You need to go in there and do your due diligence. You need to establish your EAP. You need to make sure there's an AED at the venue, have a discussion with the EMS team there, figure out how you're going to spine board, how are you going to get to the rig, just things that we do when we cover football. We have like our Big Ten medical timeout. You need to do the same thing when covering MMA. It's always good for you to get there pre-fight to meet with the promoter and the referees to discuss some of these considerations. So I was asked to talk a little bit about injury consideration. I'm going to briefly, so way back in 2011, I just kind of did a current review of injuries in MMA. I'm going to talk about just some of these quick findings to things that you might consider when you're covering MMA bout. This was just a meta-analysis, systematic review. And what you'll see here is at the top, most of the injuries that you're going to see in these are going to be head and neck injuries, by far and away the most common injury, followed by upper limb, then lower limb, and then trunk. Type of injuries, again, as we've seen, and I think I saw this to be as well, lacerations and abrasions are very common. Fractures, dislocations can be very common as well, muscle and tendon injury. This is pretty interesting here. So I think a lot of the studies that you're going to see that look at injuries in MMA are basically video review of competition. So people are just watching videos and figuring out what kind of injuries happen. But you'll see that actually the majority of the injuries occur while people are training. So we may be missing some of these injuries in some of these systematic reviews. This, I think, makes sense. So in more of the striking predominant disciplines, you're going to see more injuries to the head and the face, whereas more submission predominant disciplines is going to be more joints and extremities. This slide basically says the heavier you are, the higher risk of potential injury. And then amateur has a higher risk versus a professional. I've seen this to be mixed, but this study showed that to be the case. And then as you can imagine, match outcome, the losers have a much higher incidence of injury. If you have a KO or a TKO, obviously a higher incidence of injury as well. Just some general numbers, rate of injuries as far as athlete exposures for males, 246 per 1,000 athlete exposures, and females, 101. We see in this study here, the professionals had a higher incidence versus the amateurs. And similar with some of the other studies, we see the head and upper extremities being the higher incidence. Head injuries are still extremely common. The overall injury rate, they know to be 50 out of 100 athlete exposures for this injury. And in this review, they looked at 285 UFC bouts, and they found that the head injuries demonstrated about 2/3 of the total injuries. With this, we saw that of these head injuries, 83% of these people with the head injuries lost the fight. If the fight ended in a TKO or KO, 60% of those had a head injury. And with, you can imagine, with increased weight, increased power, increased incidence of a TBI. I'll try to be fast here because I don't want to take up all the time. So I want to talk just a little bit about hydration. We all saw back in the 90s where we had rapid dehydration methods in college wrestling, and this led to improvements and better wrestling weight loss patterns because of the day of the competition weigh-ins. What we've seen is weight loss we know can adversely affect people's ability to perform, but it's still rapidly done in MMA. These are just some studies looking at many MMA fighters lost about 10% of their body mass in the week before their competition. This is pretty classic. So here's some of these recent UFC fights. You'll see people have had 16% weight change from the date of weigh-in, which is usually on a Friday, with the competition being on a Saturday. This individual here gained 25 pounds from weigh-in until fight day, and this is not uncommon. We see this a lot. Some of the methods with which people do lose weight: sauna, diuretics, water loading, very concerning ways. And why possibly in MMA versus the other sports? And really, this is because of the time between weigh-in and a competition. So imagine you have a big boxing fight or a big MMA fight where people have the fight on Saturday, but it may be a per-view fight. They're going to want to make sure that the athletes have made weight. Imagine having a bunch of friends over, and then all of a sudden, 5 minutes before the competition, someone doesn't make weight. That's going to be problematic. So that's the biggest issue with MMA, is the time between weigh-in and competition is usually 24 hours. It is concerning. People have called to ban this rapid weight loss because if you think about the definition of a prohibited substance, it can endanger the athlete's health and violate the spirit of the sport. And there's a question, does it truly enhance a performance? But we see that a lot of people are doing it. It's kind of the level playing field. If you're not doing it, your a competitor may be. So some organizations have made good gains or good changes with respect to hydration. So the One Championship banned weight cutting by dehydration, and they had them weigh in 3 hours before the event. Unfortunately, the UFC really hasn't taken this to heart. So they've actually extended their time from 24 to 36 hours. And that has me concerned. But again, the most concerned are some of these smaller organizations where maybe we don't have this oversight. The ARP, again, that organization that I mentioned, their consensus statement on weight loss, they said should be 24 hours or less before competition, just like in wrestling, maybe consider certifying weights and keep this in a data bank that would be accessible for us to all review. Some concerns about a weight loss and a hypohydration. Sometimes we worry about some maybe mimicking of concussion symptoms or exacerbating concussion symptoms because of this hypohydration. And it's hard to really tease out or differentiate if some of the symptoms are secondary to rapid weight loss or from a concussion. So this is pretty exciting. We're currently doing this here at Ohio State. We have a clinical trial. We have 20 combat sport athletes. That's our plan right now. We're currently enrolling and currently testing. And we're actually going to test people. We're going to have them spar in a euhydrated and a hypohydrated state. And at each of these sessions, we're going to assess neuromuscular control, concussion-related symptoms, oculomotor symptoms in this euhydrated and then a dehydrated state, and then engage in live sparring. We're going to monitor their head impacts with instrumented mouth guards and video analysis. And then post-bout, we're going to collect, again, the concussion-related oculomotor symptoms. So pretty exciting. Our hope is that we can, try to say it is more beneficial to participate in a euhydrated state than a hypohydrated state. This was also mentioned. I think it's a pretty interesting with respect to the boxing. A consideration, it's the amount of blows that occur right before someone is about to get knocked out. So many times you can have many blows in that state. So we need to talk to, as we start to think about rule changes, how we can possibly limit this, make sure our refs are appropriately trained to notice somebody in a state where they're unable to intelligibly defend themselves. The last little bit to talk about is just the concern. Again, a lot of these smaller gyms, we don't have the follow-up. We're blessed at places like Ohio State where I see my student athletes every day after concussions. A lot of these people are unfortunately lost to follow-up. So a lot of them go back to practice without any kind of a follow-up. They may be banned from a state-related competition, but no one's really back at their personal gym to decide when they're even engaging in any kind of physical activity, much less sparring. You see many of these people this is just an internet forum. 60% of people return to sparring after just 2 days after sustaining a concussion, with the average rate of returning was 5.6 days. So really concerning stuff. Again, possible we can act on a state or even hopefully on a federal level to see if we can institute some kind of widespread rule changes. So again, you'll see here some more kind of surveys about people, how quickly they return to activity. 40% returned the same day they had a head injury, and they willfully admitted they're hiding symptoms from their healthcare provider. So again, some of the inherent gaps is that we do see some variations from state to state, and they still sometimes, unfortunately, some of the organizations do have kind of more strict, maybe arbitrarily timelines for TKOs and KOs, and I think that might not fully be in line with our current understanding of our recent concussion consensus statement. For your review, this is what the ARP states with respect to their concussion guidelines and time off. Again, maybe not the most evidence-based when you have really kind of strict days, 30, 60, and 90 days. I think it should be more individually based. And I will stop there because we're running out of time. So thank you very much.
Thank you, Dr. Walrod. Now it's my pleasure to introduce our fourth speaker, Dr. Mark Lavallee. Dr. Lavallee received both his undergraduate and medical school degrees from Pennsylvania State University. After completing a family medicine residency at York Hospital in York, Pennsylvania, and a sports medicine fellowship at the Crozer Keystone Health System in Philadelphia, Pennsylvania, he acquired the CAQ in sports medicine and his certification as strength and conditioning specialist from the NSCA. In 1998, he started 2 ACGME accredited sports medicine fellowship programs. The first was in South Bend, Indiana, at the University of Notre Dame, and the other was in York, Pennsylvania, with WellSpan Health and Gettysburg College. Dr. Lavallee has served on the AMSSM Board of Directors from 2004 to 2008, and he was inducted as a Fellow of AMSSM Distinction in 2019. He has been an associate editor of the Clinical Journal of Sports Medicine from 2004 to 2008, and had a faculty appointment as an assistant clinical professor of family medicine, currently with Drexel University School of Medicine since 2013. He held previous clinical professor appointments with Indiana University School of Medicine from 1998 to 2013, Penn State University College of Medicine from 2013 to 2020. While in South Bend, Dr. Lavallee was the team physician for numerous South Bend area high school athletic programs, head team physician for Indiana University South Bend and Holy Cross College, medical director of the Sunburst Race from 1999 to 2013, and was the team physician for University of Notre Dame men's soccer team. Since relocating back to York, Pennsylvania in 2013, Dr. Lavallee served as head team physician at Gettysburg College from 2014 to 2020, when their women's lacrosse team won the NCAA National Championship both in 2017 and 2018. Dr. Lavallee has been involved as one of the faculty physicians for the Marine Corps Marathon in Washington, D.C. since 2014. Dr. Lavallee has authored numerous papers and book chapters on various topics in sports medicine. In June of 2021, he co-authored and published his first book with Michael Askin, PhD, called Rise Above Your Sports Injury, Mental Toughness Skills to Help You with Your Sports Medicine Team. On a national and international level, Dr. Lavallee has been the International Weightlifting Federation Medical Director for the World Masters Weightlifting Championships since 1999. He has brought numerous medical students, residents, and sports medicine fellows to these championships around the globe. He recently returned with his medical team from Rovaniemi, Finland in mid-September. This is above the Arctic Circle, hometown to Santa Claus, and over 250,000 of his reindeer. Dr. Lavallee has attended the USA Weightlifting Olympic Trials in 2000, 2004, 2008, 2012, and 2016. He was lead U.S. physician for the Rio Summer Games test event in 2016. In 2016, Dr. Lavallee was elected to both the executive medical committees for the Pan American Weightlifting Federation in Lima, Peru, and the International Weightlifting Federations in Lausanne, Sui. Sorry. Dr. Lavallee coordinated as Chief Medical Officer and International Medical Staff for the 2015 IWF Worlds in Houston, Texas, 2017 IWF Worlds in Anaheim, California, and 2018 IWF Youth Worlds in Las Vegas in 2019. He was the head team physician for 2023 Pan Am Games in Santiago, Chile, and was most recently the chief medical officer for the weightlifting venue in the 2024 Summer Olympic Games in Paris, France. Dr. Lavallee dabbled as an Olympic weightlifter in the 1990s and then started volunteering for USA Weightlifting in 1997. By 2007, he became the chair for the USA Weightlifting Sports Medicine Society. For USA Weightlifting, as head U.S. physician from 1998 to present, he has covered numerous national and international events for our national, junior, and senior teams around the world, and he has also covered the Olympic team's trials prior to Sydney 2000, Athens 2004, Beijing 2008, London 2012, and Rio 2016 Olympic Summer Games. Most recently, Dr. Lavallee was appointed as the Chief Medical Officer for the weightlifting venue at the 2024 Summer Olympic Games in Paris, France. Dr. Lavallee also has provided medical directorship to national/world events for USA Fencing, USA Boxing, US Whitewater Canoe/Kayaking, and USA Team Handball over the years. In June of 2022, Dr. Lavallee was the first non-athlete, non-coach inducted into the USA Weightlifting Hall of Fame in Las Vegas. Dr. Lavallee's professional interest lies in teaching point-of-care ultrasound, performing ultrasound-guided invasive procedures, strength sports, the hyperflexible athlete, and Ehlers-Danlos syndrome, and dry needling. At UPMC Central Pennsylvania, he runs a scoliosis clinic, 2 sports medicine offices, and his Ehlers-Danlos clinic is run out of his family medicine office in the York and Harrisburg area of South Central Pennsylvania. While he's not seeing patients or traveling with Team USA, he enjoys time with his church, his family and friends, boating, scuba, weightlifting, long-distance open water swimming, firearm restoration, and restoring his 3 antique Willys Jeeps. Dr. Lavallee, you have the floor.
Sorry about that intro. Didn't think you were going to read it all. Hi. I wanted to say really enjoyed Brian's talk on MMA and Michael Kelly's talk on boxing. I spent 15 years with the Fighting Irish, and they had a big boxing, amateur boxing. We would have, and this might make you cringe, Michael, but we would have 200 bouts that would start at 3 o'clock. We'd go to like 1 or 2 in the morning. It was all amateur, but that's where I learned a lot about boxing. And Tom Zibikowski, who was one of our football players, holds the record by the NCAA to be the first amateur football player to become allowed to be a professional boxer. And he went on after Notre Dame, went on to play for the Ravens and some other things. So I am probably maybe the oldest person here, so I apologize for the learners on the call. Thank you for taking time out of your busy life, post-call, pre-call, or on-call, to spend time with us old people. Number one. Number two, my only bit of advice is the power of yes. And the only reason I'm here tonight is because I don't know how to say the word no. And will you cover this? Yeah, sure, I'll cover it. Yeah, I'm post-call, I haven't slept in a day or two, but yeah, I'll cover team handball. I don't know anything about it, or learn about these different sports. Well, let me see if this works. Okay, so disclosures. I have no financial disclosures. Been with USA Weightlifting since 1997. I started off as an amateur weightlifter, and I've been with the Pan Am Federation since '03 and the IWF since '99. All the athletes I'm going to take pictures of, giving me permission to use their likeness. I'm not paying them for their likeness. They're kind enough not to charge me for their image and likeness, because weightlifting has no money in it. Okay. Bodybuilding, Arnold Schwarzenegger, that's a different story. But we'll talk about him later. I was a really bad Olympic weightlifter, never made any national teams, broke any records, so I decided to become their doctor. This is us in Rio. So how did I get involved with weightlifting? I have Ehlers-Danlos syndrome. If you haven't learned about that yet, you will. And I was morbidly obese and fat and had low self-esteem. And the guy that sat next to me in organic chemistry was the probably best looking guy I've ever seen, with muscles coming out his earlobes, and he was failing OChem. So I tutored him and he trained me, and I changed my life, right? So that's how I got involved. We're going to talk a little bit about different types of strength sports briefly, history of weightlifting. We'll probably breeze through this because I don't want to go over time, and I have a tendency to do so. This is me. Don't laugh. Long time ago. If you love the tight shorts and the tight white socks, yeah, that's welcome to the 90s. And so I started weightlifting in 1987. Yes, that's me with more hair and less wrinkles. And at 28, this is me at the Olympic Training Center. Doing a bottom of 100-pound clean, which is not a lot of weight in this world. Where was I yesterday? This was us yesterday at the Marine Corps Marathon. We had 35,000 runners. We had 2 cardiac arrests. Our tent had, and it was only 54 degrees. Okay, so race medicine is very different than weightlifting. But if you're going to be a sports doctor, as probably Michael, Bryant, and AJ will tell you, you sort of adapt and overcome. So one minute you're, pouring ice on people, and the next minute you're ringside or on a platform. So this is our team. The Marines are awesome to work for. What's even most important is the people in the duos down below. Your brain injured athletes being pushed by their wives, their mothers, and that will bring tears to your eyes every day. Where was I a year ago on the state? A year ago on this date, I was in Santiago, Chile with Team USA, getting ready. We used the Pan Am. The Pan Am Games is 1 year out from the Olympics. We use that as our test event to sort of trial who's going to make it, who are our best and brightest for the Olympics. You'll see Olivia Reeves, who, if my work, she's sitting right here. She's our current gold medalist in weightlifting. You'll see her right here too. So this is Olympic Village, or Pan Am Village, a year ago. What did I do this summer? I got to take my family for the first time to the Olympics, and it was sort of a lot of fun. There's Notre Dame, not the University of Notre Dame, but the Notre Dame Cathedral. It was not open, but it was just a really fun time. What did I do? I also watched Grant Fisher win the bronze medal in the 10,000 meter, first U.S. medal in 58 years. Sort of cool. Got to go to Stade de France, and then the guy sitting in front of me at one day started talking to him. Turns out he was Prince Albert of Monaco. You just meet some pretty weird, cool people when you're at these things. But I also worked. It wasn't all fun. So here's Team USA. Here's the doctors that were part of my medical team here in the top. You got a doctor here from Georgia, a doctor from Lebanon, Sasha Tochabani. She actually has a practice in LA, and then Fatih is Dr. Fatih's from Tunisia. So you learn a lot about people internationally. This was a proud moment. Here you can see the first gold medal, female gold medal since 2000 Sydney Games is Olivia Reeves. She's lifting a paltry 146 kilos over her head. If you do the math, that's 322 pounds. She weighs 71 kilos. So you can see here on the platform, our last person that got a medal was Tara Knott in the 2000 Olympics in Sydney. She is married a famous wrestler. AJ may know Coach Cunningham is assistant wrestling coach at Penn State. His wife is a gold medalist. Then here's some of our team. So a couple things about myths. If you lift weights, you'll stunt your growth. That's not true, only if your parents are small and you're malnourished. If you lift weights early in age, you can injure growth plates. There's only been 3 reported physio injuries in kids from lifting. All were accidental, all were unsupervised, and that data is from 8-year injury surveillance data from the CDC, and it's a little bit dated. It's from 1997 to 2000. Girls who lift will look like boys or men, and that's only if you have steroids or PCS or both. And this is Jordan Dela Cruz. This is in the Olympics. I don't think anybody would say she looks like a dude. She is, and she's stronger than most men I know. This is Sarah Robles on the right. She has PCOS. She's a double bronze medalist, 3-time Olympian. Okay, and this is her with a medal in Rio in 2016. Weightlifting is a clean sport now. So the myth is because of strong anti-doping and efforts by the IOC and WADA, lifting is relatively clean with banned substance. That's not really the case. We've had a lot of issues. And you can see here, I'm not going to read them all to you, but you can look at the slides. 2019, Thailand was banned for 16 positives. December that year, Egypt was banned. Coaches were jailed. Then it came out that our IWF president steps down amid a bunch of accusations. Some countries were tied. The thing that brought me into the fold was in December of 22, I got a call by the president of IWF. We had a competitor in the female category during doping testing had a penis, and it wasn't in a jar, it was attached to the body, and that was sort of an issue for a female competitor. So we did not have a gender identity policy. We were the last sport not to have one, if you can believe that, in just 2 years ago. So so what are the types of sports? What strength training? There's strength training, bodybuilding, powerlifting, weighted throwing, and weightlifting. So real quickly, strength sports is what most Americans actually do, but they call it weightlifting. Okay, this is just repetitive resistance. People go to the gym and throw things around. There's really no competitions other than strongman and Highland Games, and no anti-doping. NSCA, National Strength and Conditioning Association, sort of regulates some of this. Bodybuilding. This is what most Americans think when you say you're a weightlifter. They think you're a bodybuilder. And this is an appearance resistance sport. This is a guy named Ruf Rigno. For those of us with gray hair on this call, you remember him in green, and he was called the Incredible Hulk. Okay, those of you that haven't, look him up. You'll see him in green with a really bad wig on. This is a picture of him at 58 years old. Yeah, that's not natural. Okay, and Arnold Schwarzenegger in 1972, that's not natural either. Okay, so this is a sport where you use resistance, and in many cases, I hate to say this, drugs, and you get superhumanly big. Okay, it's an image sport. Okay. Powerlifting. This is what most Americans think when you say competitive weightlifting. They think, oh, how much you bench press, how much you deadlift, how much you bend or squat. That is powerlifting. That's not Olympic weightlifting. You can see there's different competitions, different ages. You guys can all read this. I won't bore you with it. But basically, the bench press, the deadlift, there's a picture start and end, and then the squat. Okay, Olympic weightlifting, which is what most people, the world calls it weightlifting. Americans call it Olympic weightlifting because we're so confused because we have so many different things we do in America. So this is just two things: the snatch, which always gets people to chuckle, and clean and jerk. Right. So this is Niam Sulaimanoglu, the pocket Hercules. He was about like 3 chromosomes away from being a midget. I don't know if I can say that word, or a vertically challenged human, but maybe probably the better term. But you can see short arms, short legs, and you can see his butt is almost kissing the ground. Very flexible dude. Unfortunately, he was an alcoholic, and he passed away from liver failure after a liver transplant in Turkey. But he was a gold medalist in the Atlanta Games. Really nice guy. You can see at the bottom is the clean and jerk, where you lift the barbell off the ground to your front of your shoulders. You drop down, and then you explode up. It's not a press. You're literally, the bar is on your chest, and you're flying up, and it leads up, and you receive it, and you land it overhead, and you catch it with your arms. There's no pressing at all in that. So that's what Olympic weightlifting is. Weighted throwing. This is what most Americans call field sports. You swing around and dance in a circle with yourself. You're holding something super heavy. It's either something like a shot put, a discus, or this lovely thing that looks like not a hammer, but that's what they call a hammer. It looks like a bowling ball on a rope. Okay, and you swing around until you're so damn dizzy you think you're gonna puke, and you let it go, and hopefully it goes the direction you want it to, and it doesn't go into the net or around you. At the Olympics, they did this discus, and they used, I've never seen this before, little RC cars that would zip out because they didn't want anyone to get hurt. These little cars would zip out, and they put the referee would put the discus on the little RC car and go back to the athlete. It's super cool. So here's the snatch. You get 3 attempts. of each of these. I'm really sucky at tech, so I tried to put video in here and it didn't work, so I apologize. But bottom of the snatch here at the top, and sort of this is before the takeoff at the start, bottom of the snatch, your butt's down, the arms are really wide, this is Ed Herger, and then after you pull it up over your head, you got to do something standing up, and that's the finish. Okay. There's other doctors. Dr. Clugston, that was, I'll go, if I could go back, Dr. Clugston was my fellow at Notre Dame. Now he's the head team physician at University of Florida. This is the clean and jerk. This is 2 motions. This is where you start in the start position again, similar to the snatch, but hands are closer together. You clean it to your shoulders, okay, and then you press it overhead. Not press, but you jerk it overhead, excuse me. So this is two fluid motions, and you can see here's Sarah Robles, who we talked about earlier. This was in 2017 at Worlds, and then you can see there's different types. You go into a split stance, which looks like it's not going to work, but it gives you a tripod underneath, and then you bring your legs together, and that's a finished position. Brief history of weightlifting. It goes back to the ancient Olympic Games. This is a stone. It's 140, if you can believe it, it's 143 kilos. Okay, so it's just shy of 330 pounds. And yes, they did not have steroids back there. They just ate like pancreas of like goats and stuff like that to try to get whatever hormones they could. But you can see the handholds on these stones, and they would lift these stones heavier and heavier. This is one of the heavier stones. You can see the notch marks on the top here. Then the ancient games went out. They had circus strongmen, and then the modern Olympics started in 1896. And an athlete that was a strength athlete had 6 moves: squat, bench, and deadlift, which are all the what we call powerlifting, the clean and jerk, one-handed snatch, and two-handed snatch. Here's a picture of a one-handed snatch. And that's why there's knurls in the center of the barbells that you have today. In 1948, they dropped the one-hand snatch, was dropped from the Olympics. In the 50s, they had the split snatch. Okay, so if you think you're going to pull a hammy or your quad tendon, this is how you do it. You do a split with like 300 pounds over your head. Great way to like really make your hernia get angry. By 1964, powerlifting and weightlifting split. Okay, and a weightlifting stayed in Olympics, powerlifting did not. Now this is the crazy part. In 1988, women were allowed to start lifting. Okay, the first Olympics that women lifted at was 2000. Okay, not too long ago. I mean, to me, I remember 24 years ago. Some of you may have not even been born yet. That's sort of weird. I'm that old. But some of the speakers, like I actually remember 2000 Olympics. And Tara Knott, who is married to Coach Cunningham, she was the first athlete to be in 3 sports in the Olympic Training Center. She started off as a gymnast, aged out of that in the teens, became a soccer player, aged out of that and came to weightlifting at the age of 23 or 4. And before she turned 30, she was at the Olympics for her first sport, weightlifting. Okay, our first woman VP in the IWF was 2017. So women have really come a long way, which makes this whole gender thing that we've been dealing with our sport even more important. Get it right. What are the big injuries? Okay, these are all groaners. Elbow dislocations, yes, the olecranon should not be pointing forward, but when you have 389 pounds over your head, the elbow can sometimes go the wrong direction. So elbow dislocations, UCL tears are very common. When you drop, you can see our Ukrainian weightlifter here. He bent forward, so the bar hit him on his scapula, causing a little bit of a fracture on top of an elbow dislocation. But the other thing is if it was a little bit higher, when that hits on the back of the neck, you develop a clay shoveler's fracture, where you actually shear off the spinous process, as you can see down below. Okay, this is a nice groaner. This was the Beijing Games, and Janos Barani, Hungarian lifter, dislocates his elbow. Once again, the olecranon should not point forward and be that close to the biceps. Okay, he's obviously not having a good day. You can see the bar hitting him on the back and rolling down. Here he is, and here as we're trying to take care of him, you can obviously see the olecranon. The actual really cool picture I couldn't get was I just saw him lift in a master's event in Rovaniemi, Okay, so fast forward almost 16 years, and now he's like 40 something years old, and he's back lifting like amazing, and after an injury like this. Okay, so you can come in. Other things, lumbar spine strains are very common. Herniated nucleus pulposus. Here's someone with a quad tendon rupture. Here's someone with an Achilles tendon rupture. Remember, when you think they're either old, they're on anabolic steroids, or they just took fluoroquinolones. Okay, or maybe they're an old dudes on steroids and just took Levaquin. Then they're really hosed. Okay, but you laugh. It's a real thing. It's probably one of those things. And when I'm covering the masters, it's like last year we were in Krakow, Poland, and we had a 54-year-old from Kansas, and she was lifting, and she had a knee replacement, and she goes down to the bottom of the clean, pops, knees goes out, so she ruptures her patellar tendon over top her knee replacement. Nice thing is Krakow is a support city for the Ukraine, so their trauma surgeons are amazing. So we had her in the operating room in like less than like 6 hours. Little 54-year-old from Kansas. Other chronic things, DJD, degenerative disc disease, patellofemoral pain. A couple things that are unique is you can get scapholunate dissociation. You can see that right here. It's called the Terry Thomas sign, or the anybody has a gap in their teeth. It looks like a gap in the teeth. Clenched fist view is going to be healthy for that. We do put pins through that. Posterior osteophytes from landing weight over and over again, or a posterior ganglion, and you can get a pump bump. We won't go over the gender issue because I am out of time. But if you're interested, you can contact me. I'll go over that. I love practicing the spinal cord injuries. We do it all the time. We drill. We always have a huge medical team, and we're multifaceted. We have chiropractors, doctors, medical students, residents, fellows, physical therapists, massage therapists, and everybody has to be part of the team. And we work together. A couple last quick ones. This was a gentleman. This is cool. This guy was when we were in Bordeaux, France. And if you look carefully at this still picture here, you can see his quad above. So this is, he ruptured his quad tendon on the left. Okay. In this next shot, he's going down. Here's where he ruptures his deltoid ankle ligament on the right and his ATFL on the left. So this guy's in a world of hurt. Okay. He goes down, and this was 2005 in Bordeaux. That was about 130 kilos. Old guy. What's crazy, 9 years later, here's this guy in Copenhagen. He's back. We had sent him to France. But the interesting thing, the Croix Rouge, okay, Red Cross, sitting right there. And we say, okay, found out his other leg, he ruptures his patellar tendon. So I'm giving, back in the day, we could carry morphine. And this shows you how old I am. I actually could carry morphine across state lines, and crazy to other countries, right? But this was a case where, trust me, when you rupture your patellar and quad tendon, you're hoping for more than a Tylenol. So we gave him morphine, and we got Croix Rouge, and that's when we found out Croix Rouge is not an ambulance service. They only are national emergencies. So know who you can utilize. Because I saw Croix Rouge, I'm like, oh, we got an ambulance, we're cool. Nope. Make sure you do your secondary survey and never give up on a master's athlete, because it takes a lot to kill these old guys. They keep on coming up. He came back 9 years later, got gold medal. This is my one attempt to show a video. This is what happens when you lose the weight. So there's the clean. Now watch his left knee and where the bar goes. Okay, so when that bar hit him on the posterior superior iliac spine, it forced his hip out of socket. This is a guy, watch his knee, right knee. That's a quad tendon tear. Okay, so those are my videos. The last one I'll show you, you make a call, 34-year-old masters weightlifter. This is down in Florida, mother of 3, lives in Salt Lake, 95 kilo class, has 77 kilos on the bar, second attach. And let's see if this works. Okay, it's not going to play. Well, let's just say it's very similar. This is what happens when she was in the operating room twice. She forced her her femoral head went through her acetabulum into her. You can see there's her morena right there. And this was after we reduced it on site. They had to plate her and take her back to the second trip. One of the toughest hip relocations I've ever had to do, and was unsuccessful on the platform. So when you think of weightlifting, it's a unique sport. It's got unique injuries. Bring a comprehensive game bag. My thing to all you young doctors and soon-to-be doctors is say yes. Okay, the power of yes is going to open more doors than the power of no. Okay, life is full of choices, and there's work hour rules and all these things, but there's nothing more powerful than saying yes when people ask you to volunteer. I think we as mentors need to pay it forward and help bring you guys up and give you opportunities. If any of you have any interest in weightlifting, here's my cell number and my email. I'd love to hear from you. Thank you.
Great. Thank you, Dr. Lavallee, for the presentation. And thank you to all of our speakers. Really fantastic panel tonight. I know that there have been some questions in the chat, and we can go through those, but I know we're running a little bit late, so I get it if you need to step out. Let's see. So the first question was, what are the best ways to get involved with shadowing and volunteering with combat sports events? Are there any certifications that you recommend for medical students or trainees?
I think I'll just echo what was just said. I think, being available and ready, yes. So I think the answer is yes. Like Dr. Lavallee was saying, be there. These are some great opportunities. Find a mentor in a sport of which you have interest and reach out. I mean, I think a lot of us are on these kind of calls and we're involved in education because this is a passion of ours. We like to educate new learners. We like to pay it forward, like he just said. So just find someone who has a similar interest and reach out. And then as well as we mentioned, I think it's also was mentioned in the chat as well, the ARP as far as ringside coverage is a great resource as well.
I would just add to that, once you complete your medical training, you have a license, don't be afraid to reach out to your state athletic control board. Some places call it a boxing commission. Most states use it because it's boxing and MMA. But don't be afraid to reach out and inquire about becoming a ringside physician. Most states are always looking for good doctors.
Great, thank you. I think most of the other questions have been answered in the chat. I did have a question. I wanted to ask about the tib-fib fractures that we've seen on some UFC fights over the last couple of years with leg kicks. And I've heard of some athletes increasing their kicking training in order to kind of beef up their bone or make their bone stronger. And what do you normally say to these athletes when they're doing this? And do you have any recommendations for them? And then does repeated bouts of rapid weight loss potentially increase their risk for these kinds of injuries?
I'm obviously curious to hear everybody else's thoughts. This has come up a lot. So we just saw in NFL football, Aiden Hutchinson from the Lions have a big tib-fib fracture. We discussed this among my colleagues and wonder, if many of these people are competing on a low-level stress fracture, maybe that they're kind of hiding or maybe hasn't fully healed or maybe they are not aware of yet. I think also we always want to check, vitamin D levels as well. That was kind of our thought. I'm curious to anyone else's thoughts. Maybe these people have been kind of sitting on a, maybe a stress reaction that just got too much. I don't know about, making the bone stronger with repetitive kicks and stuff like that. And then I'll mention about hydration if anyone else has any thoughts.
I concur with Dr. Walrod about the vitamin D, and that a lot of these fighters, I think, because they're trying to quote unquote condition the area, they actually causing small microfractures that may weaken it. Then they get in the bout and they get that real hard kick. And you see that very dramatic fracture.
Yeah, I think just conceptually, the pathophysiology of actually making that work, right? You'd have to allow for proper nutrition. You'd have to allow time for that to heal and somehow reinforce itself. before repeating the process. I doubt there's anywhere near the amount of time actually needed to theoretically make that stronger in the training camps that many of our athletes would go through for those type of fights, or even long-term training. It just doesn't seem like it's feasible.
The only thing I would add to everyone's comment is you know that with weightlifting, pick whether it's back squats or deadlifts, you're going to put a piezoelectric effect across the bone, right? And it's not ballistic like kick training is, but it does increase bone density. So maybe instead of kicking each other, they should be doing more squats and deadlifts to increase their bone density, and drinking more milk or cheese.
And then just a quick comment on your question about hypohydration. That's definitely one thing we're trying to study in our new study that we're currently undertaking, but it has certainly been shown hypohydration will decrease your ability to like react, and which I certainly put you at risk for an injury. So that it is difficult because it is kind of the norm of the sport for MMA and boxing is really this rapid weight loss. And we need to hopefully educate the fighters to say, you actually do better. You will perform better if you don't have these extremes of weight loss, but we just need to keep on studying this more.
Yeah, and I think just to add on to that, I think Aaron Hammer from Wisconsin had put out the study. It was last year, I think, in BJSM, maybe a couple years ago. Of I think it was a kilo loss was a 14% increase in hazard of injury for a wrestling injury for in-season weight loss. So I think that you can even improve on that study. I think she would admit there's maybe a couple of issues as far as exactly how she was measuring that along the way, but it was a great, at least initial study that had some eye-opening numbers.
Dr. Lavallee, how does weight loss kind of affect in weightlifting? I mean, there are weight classes, but do you find that it's really prevalent as well? Are you seeing that a lot?
A couple of things. We used to see a big issue with rapid weight loss. I mean, we'd have athletes showing up 5 to 15 pounds over their weight and then doing saunas and rubber suits and spitting and urinating. What we found, the thing that changed all that in our sport was about 20 years ago, is we took what's called a no needle policy. Because what would happen, people would literally dehydrate themselves, be one giant, and we weigh in 2 hours before competition, right? So they would dehydrate themselves, and then we have 2 hours to hydrate, and they're cramping. So everyone started IVs. So once they went to the no needle policy, we couldn't do IVs. That whole rapid weight loss became not an effective thing because they couldn't get the IV. That's what they all wanted, right? Even though we've shown that oral hydration is almost as effective, but then they just feel bloated. So a lot of some of this deals with rule changes in our sport. So but we do have that issue. It's definitely gotten better. Rule changes in sport can make it much more safe, whether it's MMA, boxing, or weightlifting.
Great. Well, thank you so much to everyone for coming. Before I conclude tonight's webinar, I do want to encourage you to join us tomorrow night. We have another great session. It'll be at 7 p.m. Eastern Time for the AMSSM SMRC webinar on plantar foot pain, pathology of joint using sports ultrasound. On behalf of the members in attendance tonight, I'd like to express our gratitude to our fantastic speaker panel that we had tonight for their outstanding presentations. And I'd like to thank everyone attending tonight's MSIG webinar. And it was my pleasure serving as the moderator. Thank you.